Merhaba.
Merhaba arkadaşlar. Başlayalım mı?
Diye senin sesini duymuyoruz ama bende mi bir problem var acaba?
Evet, ben açayım, zaman kaybetmeyelim. Good evening, dear colleagues. I am Yasemin Nasır from Sakarya. I am a medical doctor, histology and embryology specialist. Firstly, I should say thank you for agreeing to speak at the International Congress of Future Medical Pioneers 2021. This session subject is artificial organ. In this session, we'll be with Dr. Ivana Kovikova, Dr. Gabriela Turka, and Dr. Ellen Toyanaga. Our first speaker is Dr. Kovikova, MD, PhD, from Yale University School of Medicine. She is an interdisciplinary physician scientist. She obtained her medical degree from the Charles University in Prague, the Czech Republic, and a PhD degree in pharmacology from the Göteborg University in Sweden. As a visiting scientist at the National Lung and Heart Institute of Imperial College in London, United Kingdom. She works in physiology, in immunology, in neuroscience, in clinical research. Now it's time for Ms. Kovikova's presentation. It's about translational medicine. We are listening.
Hocam küçük bir aksaklık oldu. Hemen çözüyorum.
Hello from Connecticut, and thank you organizers for inviting me to give this lecture. And we will talk today about post-infectious autoimmunity in the brain. We will first touch on the relevance to current situation in our pandemic, in COVID pandemic, and realize how long-term impact can result from post-infectious autoimmunity. We will then go through a road of establishing evidence that a condition is due to post-infectious autoimmunity, which can be quite long. But fortunately, as new tools are developing, we have a chance to develop diagnostic markers earlier and hopefully bring also much more targeted and specific therapy to our patients. My motivation was primarily to discuss the possibility of post-infectious autoimmunity in COVID. And we already see case reports in literature that indicate that this post-infectious autoimmunity may be happening. It's not so surprising because strong infections are often associated with autoimmune processes. We also know that post-infectious sequelae was present in pandemics of 1918. At least one condition is well recognized, and that's encephalitis lethargica. And this encephalitis lethargica affected people for many decades after the pandemic already ended. You might have seen movie Awakenings, where Oliver Sacks described his experience with these patients and the treatment that he provided to them, though unfortunately the effect was short-lasting. So Inflammation in the brain. We are all very familiar with acute infections, and we have very good guidelines for diagnosing the acute infections, identifying most of microbial pathogens, and treating these conditions by antibiotics or antiviral medications. In chronic inflammation, the situation is a little bit more complex. It may develop due to autoimmunity, or it may be due to the impact of cytokine storms in blood vessels and having impact on the brain cells, on neurons and glia. And this may be actually part of the problems in COVID. And then we can have also situations where microorganism has not been cleared. With chronic inflammation in the brain, there is a big question when to really inhibit it and when to facilitate it, because the differences between degenerative and regenerative inflammation is not entirely clear. In this talk, when I refer to inflammation, I will talk mainly about autoimmunity and post-infectious sequelae. So to give you an impression what can happen with post-infectious conditions, I would like to bring to your attention a case of a friend of mine who was a medical student in the same year as I was, and he was very friendly, very good student, always easygoing. And then he suffered several days of fever and sore throat, and that was followed by several weeks of fatigue and large spleen, and he was diagnosed with infectious mononucleosis. Not too long after that, he was describing paresthesias, but because he was a medical student, everybody just assumed that he was anxious, and when he was persisting, he was labeled hypochondriac, and again, little later, he developed obsessive compulsive symptoms. He was very keen on washing his hands excessively. Everything had to be very organized, and his symptoms started to interfere with his life, and most profoundly, he became an incredibly good student, which would be good. Unfortunately, because of the last exam in medical school that he didn't finish because he was unable to go for the exam because of his symptoms, had another negative impact on his life. So 5 years later, he developed schizophrenia that for a long time was drug resistant, and he now currently is on clozapine, which partially controls his symptoms. Over the years, he had several times lumbar puncture, and there was always elevated immunoglobulin M. Nobody really knew what to do with this. Nobody knew what specific immunoglobulin was that, and he kept being basically in care of a psychiatrist rather than an interdisciplinary team. Similar scenario I saw later when I was working with Dr. Leckman in a child study center, where a child also very well performing after a couple of immune interventions, flaring allergies, developed symptoms that were very bothering. He was homicidal, suicidal, and eventually he also developed the drug medication schizophrenia. So what do we do for patients who present with neuropsychiatric symptoms where we don't know whether the infection was really the causative element or not? How do we diagnose them? How do we treat them? We will talk about Tourette syndrome as an example of a condition where autoimmunity was implied, and I was part of investigating the possible mechanism and bringing clinical evidence for the possibility that there is really immune system involved. So what evidence do we need when we consider a disease as a result from post-infectious autoimmunity? We need to see that there are that the disease is temporally related to onset or worsening of symptoms. We need to establish inflammatory infiltrate, and we need to demonstrate autoreactive B cells or T cells and see whether those autoreactive T cells can cause the symptoms. This is a tall order, and in a clinical setting, not trivially done. The story of streptococcal infection and post-streptococcal sequelae in Tourette syndrome started with observation of Louis Kissling, who was a pediatrician in Rhode Island, and realized that there are a larger number of patients in her clinic. She was having a clinic for ADHD and OCD, that these symptoms were higher when in seasons where the streptococcal infections were quite severe and frequent. So recognizing this temporal association, her team performed a study where they put sera of the patients versus healthy control on brain slices and noticed that the serum did bind more strongly to brain structures, especially basal ganglia, in patients who had the neuropsychiatric symptoms, OCD and tic disorder. So this implied that there may be antineuronal antibodies. And then Susvido at NIH performed plasmapheresis on a child who had presented with similar symptoms. And so this was an elegant interventional study showing that if you remove antibodies, if you exchange plasma, there is decreased swelling in basal ganglia and MRI, and also the child improved symptomatically. So there was a motivation to determine whether Tourette syndrome is related to streptococcal infections, and to do it in a really proper way. So Dr. Lackman in Child Study Center recruited one of the world-class infectious disease, Professor Kaplan from Minnesota, who had a big expertise in streptococcal infections. And they set to carry multi-site blinded prospective longitudinal studies. There were actually 3 studies over several years. And with each study, there was more detail. And the children were very well characterized by clinical scales. There was throat swab taken regularly, plus on presentation of exacerbation of symptoms. And serology for anti-streptococcal antibodies was monitored over the period, again, regularly, over a period of 2 years, and related to symptoms. The results were kind of mind-boggling and puzzling because there the results didn't bring evidence for temporal association between the group B of streptococcus infection, and it was not really entirely clear why. One possibility was that these children were taking antibiotics, because even during clinical trial, children were encouraged to take antibiotics when they had streptococcal throat. The impact of psychosocial stress was stronger, and it's newly to the streptococcal infections. And there was a modest effect of newly diagnosed streptococcal infections and future worsening of tic and obsessive compulsive symptom severity. So the results were, the association was much weaker than it was expected. But then there was published a Danish study that analyzed medical records. And so this enabled a large number of children to be involved, and from about 640,000 people who received, or children who received the streptococcal test, 350 were positive. And now they could test whether there is an increased association with mental disorder. And indeed there was, and it was especially true for obsessive compulsive disorder and tic disorder. So why wasn't the association so strong in those prospective longitudinal studies? One possibility, and very likely so, Tourette syndrome is a heterogeneous disorder, and only part of children will have immune pathogenesis involved. Others may be more sensitive to other environmental factors because of their genetic predispositions. In addition, there were not only streptococcal infection was associated with worsening of Tourette syndrome, and implying that other microorganisms may be involved. And so if we want to consider multiple microorganisms, the study would have to be much larger. And at that time when it was performed, the tools were not yet fully developed. So the other important aspect is to demonstrate that there is inflammatory infiltrate at the site of pathology, which for Tourette syndrome is considered to be mainly basal ganglia. So we were expecting to see perivascular infiltrate, like in this picture, which is from different study, different disease. And unfortunately, the postmortem brain samples that we obtained were very difficult to stain. So instead, we measured expression of inflammatory markers in those postmortem specimens, and found that indeed the children, these are adult people with Tourette syndrome, they had increased expression of mRNA, which means that there was lower number of cycle on QRT-PCR machine. So you see here the dark ones, the patients which have lower values, meaning that the expression of mRNA and that presumably also the protein was higher in TS patients in the basal ganglia. So these are several inflammatory markers. And then Flora Vaccarino's group performed a much more detailed study where the microarrays were done on the basal ganglia, and our data were confirmed. Plus, it was actually shown that a majority of genes that were affected were related to the immune system. So having these data suggested, okay, so there is something happening with inflammation really in this basal ganglia. We would love to show autoreactive B cells and T cells, but as I said, this was a tall order in the beginning. So we at least started by looking at inflammatory markers in serum, and found that indeed inflammatory markers that are characterizing the activity of T cells, TNF alpha and interleukin 12, especially the T helper 1 cells, were increased in patients compared to healthy individuals. And also in patients, they increased with exacerbation. So there is an inflammatory process ongoing during symptoms. We also found that T cells, a subset of T cells that are normally responsible for controlling autoimmune processes, are lower in children with Tourette syndrome. So if they don't have the proper defense of against autoimmunity, then this may contribute to their symptoms. And you see again here that the regulatory T cells were decreased in relation to health, in comparison to healthy children, and it was progressive between healthy mild Tourette syndrome and moderate to severe. Again, the exacerbations were associated with decreased regulatory T cell number. So we concluded that there is indeed clinical association between streptococcal infection and Tourette syndrome. That there are signs of inflammation within the basal ganglia, and there are signs of ongoing inflammation in children by studying their peripheral blood, and that they may have increased vulnerability because their regulatory T cells are reduced. In addition, we looked also at profile of immunoglobulins in these children and found a surprising finding that these children have these gamma globulinemias. They have lower numbers or lower levels of immunoglobulin A, and also IgG4, a couple of subclasses, and mostly it was one subclass or class that was affected. Only one child had two effects. So it seems that children with Tourette syndrome may have some factor that makes them predisposed to deal with infections in different way than their healthy peers. So this is a summary. We already saw this first point, and then the fifth point is that the isolated dystomal globulinias may also contribute to a vulnerability to autoimmune conditions. So all that is good, and there are some more studies and expanded studies showing that there is inflammatory component to Tourette syndrome onset. But all depends on how you control the findings. And when we are in clinic, we want to see a marker. So here is a question. What would you do if a patient comes with new onset of neuropsychiatric conditions, and you would suspect maybe like in Tourette syndrome some streptococcal component, and you already know that he was treated with amoxicillin. So what next? So you basically are interested, as clinicians, we are interested in development of biomarkers that can be tested. There are some biomarkers that are very promising. One is coming from Dr. Pittenger's lab, that he showed that children with PANDAS, with the pediatric autoimmune neuropsychiatric disease associated with strep, had increased levels of antibodies that bind to interneurons within basal ganglia, cholinergic interneurons, and that this increased level and increased binding is actually prevented or resolved by treatment with intravenous immunoglobulin. Another marker comes from Moleculara, which is a lab that was established by Dr. Cunningham in Oklahoma, who is a scientist very well recognized for autoimmune carditis. And she also stepped into the field of post-streptococcal conditions in neuropsychiatric conditions in children, and developed the panel for plasma levels of different markers: antidopamine, anti-lysoganglioside, antitubulin, and calmodulin kinase antibodies. The problem with both these markers are that they need to be expanded and tested greatly, but it is a relative beginning. So as you see, the diagnostic markers are still not fully established, though there are some promises, and probably they don't catch every child or every person with autoimmune condition, and the panels will need to be expanded. But similarly to the problems in diagnosis, we have also issues with treatment. This is a paper that was published very recently and from Stanford, and it shows that clusters of people, how they are treated when they have the acute onset of neuropsychiatric conditions. So you see that antibiotics are involved, the non-steroidal anti-inflammatory cortisone, immunoglobulin, intravenous immunoglobulin, and the rituximab, which practically rituximab depletes the B cells and eventually leads only to depletion of memory B cells, where we assume are the autoimmune B cells as a source of antibodies. There is not listed plasmapheresis, which should be also here, which is plasma exchange, which removes the antibodies that already are produced and circulate in the body. So this is where we are now. And that took over 3 decades to reach this point. And the question is how to do this research much faster and save people, more people, and more effectively. And so here are a couple of things where I think the big acceleration will come from. We need to have more information about cerebrospinal fluid, and though there are a few studies about cerebrospinal fluid contributing to the idea that there is inflammation happening, we need much more thorough analysis of cerebrospinal fluid. The problem is that we cannot really get cerebrospinal fluid in children without proper indication and that would justify the invasive approach. So if there is an inflammation, in contrast, in those children who come with neuropsychiatric syndromes, they not necessarily have infection going on right at that point, and they may not have fever or enlarged or enhanced the white blood cell count. So the important thing will be to have evidence from imaging studies that there is inflammation in the brain that will then justify doing lumbar puncture and obtaining cerebrospinal fluid. There are some very promising studies that may be able to detect even small inflammation using the molecule TSPO, which is actually a marker of increased metabolism. But those studies are being developed, and once this is established as a good marker for local inflammation, we will be able to take lumbar puncture, and then the cerebrospinal fluid can be analyzed by high-yield technology for transcriptome, proteinome, for anything that lipidome, and this will provide a much bigger insight into what's happening in the local side in the brain. And as a consequence, we will see much better diagnostic markers. In addition, the immune therapies are not cost-free, not only monetary cost, but immune therapies, if you suppress immune system, there is always a cost that somebody becomes more sensitive to infections. So the goal would be to provide targeted and localized therapies, and there are already some examples, not clinically to my knowledge, but there are already experimental models showing that intranasal administration of small tiny vesicles that contain the for example, siRNA, microRNAs that can target and influence locally the inflammation and reduce it without having major impact systemically. So if you have any questions, please do feel free to email me. And with that, I will just say goodbye and thank you very much for your attention. Take care. Bye.
Thank you so much, Dr. Ivana Kovikova, for sharing her precious presentation. Answer and question are in the microcosmos. Başak, söz sende ikinci konuğumuz için.
Teşekkür ederim. Bu arada Doktor Ivana'nın konusuyla ilgili bir iki şey söylemek istiyorum. Özellikle tabii konu nöroimmünoloji olunca söylemeden geçemeyeceğim. Hepinizin de bildiği gibi oldukça aslında güncel bir konu nöroimmünoloji. Bizim de üniversitemizde nöroimmünoloji araştırma merkezi kuruldu İzmir Demokrasi Üniversitesi'nde. Oradan da arkadaşlardan biliyorum. Oldukça güncel bir konu. Ben keyifle dinledim. Kendisine teşekkür ederiz. Aramızda yok gerçi ama hem güncel nöroimmünoloji hem COVID-19 pandemisiyle alakalı olarak kendisine teşekkür ederiz. Şimdi sıradaki konuşmacımıza geçmek istiyorum. Bu arada ben Başak Büyük İzmir Demokrasi Üniversitesi Fakültesi Histoloji ve Embriyoloji Anabilim dalında görev yapıyorum. Ve bu kongrede bulunduğum için çok mutluyum. Yine derneğimize ve Bahar Uslu hocamıza da çok teşekkür ediyorum. Now I'd like to announce Dr. Gabriela Turk for her presentation entitled Artificial Intelligence in Dermoscopic Skin Cancer Recognition and Assist During Pandemic Time. Dr. Turku is an assistant professor on Yale University School of Medicine, Colentina Clinical Hospital. Her main field of interest is oncodermatology. Here is Dr. Turku's talk. And videosuna geçebiliriz. Video başlamadan önce de biraz bir iki şey söylemek istiyorum. Konuşmacılarımız burada olmadığı için soruları almadık ama katılımcılarımıza belirtmek istiyorum. Zannediyorum soruları sonrasında da alabiliyoruz diye biliyorum. Platform üzerinden. Onu da hatırlatmak isterim. Yine Bahar'ın da söylediği gibi videolara da 2 ay boyunca tekrar ulaşılabilecektir. Katılımcılarımıza tekrar hatırlatmak isteriz. Evet.
Turkey. First of all, I would like to express my pleasure to organizing committee and Dr. Bahar Uslu for such an exciting congress. And I will try to talk about our future expectations in ART cycles. There are some troubles during IVF treatment, even though advances, and I want to talk about most common ones: embryo selection, advanced maternal age, and fertility preservation. The selection of viable embryo remains a principal challenge of IVF. This is essential in order to predict live birth, and maybe in the future artificial intelligence will help us in this trouble. And what is the artificial intelligence? It's defined as the use of complex algorithms.
Evet, Doktor Gabriela Turku'nun videosu başlayacak şimdi, değerli katılımcılar.
Good afternoon, dear colleagues. My name is Gabriela Turcu and I'm a dermatologist in Romania. I would like to thank Professor Baharuslu for inviting me to present our future plans at International Congress of Future Medical Pioneers. My talk would be about the roles of artificial intelligence in dermoscopic skin cancer recognition during pandemic time. The main points will be about the skin cancer impact worldwide, about the changes in dermatological settings during pandemic and their consequences, the roles of artificial intelligence in dermoscopic skin cancer recognition, and the conclusions that we draw from our work in 2020. Skin cancer are the most common form of cancer in the Caucasian population. It represents with a significant morbidity and mortality. Among the three most common forms of skin cancer, melanoma is the most aggressive one. It is responsible for almost 20,000 deaths each year in Europe. It represents an important public health burden through its continuously increasing incidence. When it is discovered in early stages, it can be easily excised and the patient can be considered cured. But in advanced stages, it has a high mortality rate and requires complex and expensive care. All this justify an increased commitment to early detection and prevention. The 5-year survival rate for cutaneous melanoma for localized disease is a good one, 99%, but it drops down to 25% in stage 4. And our efforts for early detection are even more affected by SARS-CoV-2. COVID-19 has affected those disciplines where close contact is required or where there is no need for urgent care such as dermatology. This interruption to the healthcare system led to delays in the diagnosis and treatment of melanoma with devastating consequences for the patients. Neglecting melanoma during this crisis can result in increased mortality, morbidity, and healthcare costs. And we already have data showing this, especially from the most affected area by COVID in northern Italy. The number of new primary melanoma detected was almost 3 times smaller in the first 4 months of 2020 compared with the same period of time from 2019. Of course, this is not a real decrease induced by increased indoor activities. It is just reflections of melanoma that stayed home because patients feared to present to the hospital for the risk of infection with SARS-CoV-2. And we can see now the consequences of melanoma staying at home. We already have data showing the evolution of melanoma new cases and the melanoma severity during the first 6 months of 2020. A group of dermatologists and surgeons from northern and central Italy evaluated the number of cases during the pre-lockdown period in 2020, during the lockdown period and post-lockdown period, and evaluated the thickness of the tumor. And we can see a significant increase in the thickness of the melanomas, which means a worse prognosis. So me and my colleagues were asking ourselves what to do. With the COVID-19 pandemic evolving and no clear solution in sight, we considered teledermatology even more. Previous studies have shown that teledermatology is adequate for many inflammatory dermatoses, but it is not good enough for diagnosing skin tumors. Melanoma diagnosis is notoriously difficult, even for experienced dermatologists. And dermatologists should be cautious and continue seeing patients with pigmented lesions in person due to the necessity of early surgical intervention. Why? What can we do more in a face-to-face consultation is dermoscopy. That helps us to see details of the deeper structures of the tumor, and it has been proved to increase to 80% the diagnosis accuracy. And what would help us even more in this difficult year, it is teledermoscopy, a novel diagnostic service that has improved access to specialist dermatologist care for patients with skin lesions of concern, and offers a better, earlier, and more convenient secondary service in support of primary health care. This concept was discussed since 2012, but was not implemented in Romania as GPs are not trained in dermoscopy and they do not own a dermoscope. When implemented in New Zealand, the virtual evaluation showed that from 200 patients, 88% did not require further face-to-face evaluation. And in this way, patients with skin cancer could be prioritized and placed directly on surgical waiting list. So, if our GPs are not trained in dermoscopy, we thought that maybe we can help them with artificial intelligence. Over time, several strategies of automated computer image analysis have been investigated to help physicians to provide high diagnostic accuracy for melanoma screening. But all these approaches were limited because they used man-made criteria. And a real improvement was only in 2017 when specialists used convolutional neural network for image-based classification. And this new system uses its own diagnostic clues after it deconstructs the digital image down to the pixel level. And in 2018, the man was evaluated against the machine, and most dermatologists were outperformed by this convolutional neural network. And later, in a larger study, CNN also outperformed 136 dermatologists out of 157. And facing this cruel reality, we decided to take the most of it, especially that we needed it more. Even if this data may not be very accurate because we do not have a national registry for melanoma, it is for sure that melanoma diagnosis occurs at a much later stage in Romania than in Sweden, for example. So for us, pandemic will have even a greater impact. Higher stages mean higher costs and severely reduced survival rate. So we are continuously thinking of a solution. And all the data presented in the previous slides represents the reasoning behind our project that I want to present in this Congress of Future Medical Pioneers. We proposed a platform that will help family physicians and dermatologists to diagnose melanoma earlier, more accurately, and more efficiently, so we can help more patients from different geographic areas. And the project involves two teams. A technical team that developed the artificial intelligence diagnosing algorithm and creates a platform that will use automated image processing enabled by artificial intelligence to identify skin melanomas. For each lesion, the software calculates a score translated into a percentage risk of malignancy. And the second team of clinicians that includes GP and dermatologists from referral sites. For the development of artificial intelligence diagnosing algorithm, we constructed first a database and tested and trained our algorithm on it. We already had more than 100 cases, and our immediate goal is to grow this database to at least 300 cases of pigmentary skin lesions, with around 20% of cases being melanomas. So this will provide a large enough sample to test and run our trained algorithm for the first time using a genuine Romanian dataset. We also use the international skin imaging collaboration databases to train our soft and also to improve it by adding more and more cases. The clinical program includes family practice offices across the country and selected dermatology offices that will serve as referral sites for practitioners, family practitioners, for patient in-person follow-up and further evaluation and treatment. How it will work? What is the architecture of our project? The clinical images will be captured by the caregivers using a dedicated mobile phone with an add-on dermoscopy capabilities. All the clinical skin images will then be sent to the cloud artificial intelligence engine for processing, and the results will be sent back to the caregiver. So family practitioners will be able to forward the high-risk clinical images to the dermatology experts for further evaluation and treatment. All the image database will gradually increase, and it will also serve to periodically retrain the artificial intelligence model so we can constantly improve its performance. While the CNN architectures is difficult to set up and train, its implementation on digital dermoscopy system or smartphone application may be easily deployed, so that physicians of all different levels of training and experience may benefit from assistance by a convolution neural network image classification. This is not a perfect system, of course. There is a limitation regarding the number of centers that we can develop, and the technique itself is limited by the lack of total body skin examination. As the clinical significant lesions may not have been appreciated well by the referring physician, like in this case, where the patient was referred for the large brown-black tumor, when in fact the concerning lesion or the pink smaller one was the pink smaller one. And the studies show that 40% of excised melanomas were detected by total body skin examination of patients that were attending the clinic for another reason. But we think that in time we may overcome at least partially this limitation, as the GPs involved in this project will be more trained and more aware of diagnosing the skin cancers. In conclusion, 2020 was a permanent balance between the risk for treatment delay versus risks for SARS-CoV-2 infection, and telemedicine has somewhat bridged the gap for in-office visits. Teledermoscopy may prove to be a valuable diagnostic tool for patients with skin cancer, but we had to overcome the limited number of dermoscopy-trained doctors, so we consider the role of artificial intelligence, because studies have shown that our artificial intelligence performance was on par or sometimes even outperformed the specialists in diagnosing skin cancer. And with a relatively small involvement, we can develop a software tool and an associated clinical program suitable for 2020 that would facilitate cutaneous melanoma screening by GPs and provide diagnostic support. This offers and improved access to expert care for patients from rural areas with reduced travel costs and waiting times. So, despite many problems, we can see 2020 as an opportunity for us to invest in learning and implementing dermatology, teledermatology, and artificial intelligence in the clinical practice so we can face any future challenges. Thank you for your attention, and I wish you a very fruitful meeting.
And we thank the Dr. Turku for her valuable presentation. Doktor Turku'nun konuşması için kendisine teşekkür ediyoruz. Yapay zeka birçok alanda olduğu gibi dermatolojide de uygulamalarla kendine yer buluyor. Bununla ilgili de özellikle onkodermatoloji ile ilgili konuşması için çok teşekkür ediyoruz kendisine. Şimdi sıradaki konuşmacımızın sunumu için ben sözü Şadiye'ye bırakıyorum.
Merhaba, Antep'ten herkese iyi akşamlar diliyorum. Ben histoloji embriyoloji uzman hekimi Doktor Şadiye Can Polat. An itibariyle sunum yapacak olan Doktor Ellen Toyonaga'dan birazcık bahsedeyim. Kendisi Hokkaido Üniversitesi'nde tıp lisansını aldıktan sonra aynı üniversitede doktorası tamamlamıştır. Daha sonra Yale Üniversitesi'ne geçerek orada postdoc çalışmalarını cilt hastalıkları üzerinde yoğunlaştırmıştır. Şimdi sözü Doktor Ellen Toyonaga'ya bırakıyorum. Herhalde video yüklenmesi biraz vakit alacak.
Bu arada Doktor Gökşen Derya Reis Köse sanıyorum söz istiyor. Aslında bu arada söz verebiliriz diye düşünüyorum sayın hocalarım. Buyurun Gökşen Hanım. Gökşen Hanım bağlanamadı herhalde. Evet. Evet. Gökşen Hanım bir el kaldırmıştınız ama ses kapalı. Sanıyorum bir aksilik oldu. Peki, o zaman sıradaki videomuza geçebiliriz zannediyorum. Sıradaki konuşmacımızın videosuna. Evet.
Thank you for the opportunity to talk here today. Today, my topic is the future of wound healing and artificial skin. These are the contents I'm going to talk. Skin is the largest, multifaceted, indispensable organ. The primary function of the skin is anatomical barrier between the internal and external environment and serve as a protective barrier against the environment. Severe injuries to large portions of the skin compromises the protective functions of the skins, such as thermal regulation, water retention, and sensory relay that may result in major disability or even death. The primary goals of injury treatments are rapid wound closure and the functional, aesthetically satisfactory scar. Recent advances in cellular and molecular biology technology have greatly expanded our options in wound treatment. These are the ideal characteristics for wound treatment: protective barrier, control water evaporation, support neovascularization, minimize scar formation, and improve aesthetics. Provide ideal environment for accelerated wound healing. Have multisensory, easy to manipulate, cost-effective. Unfortunately, we haven't had a substitution of real skin with all these characteristics. The process of wound healing is compromised in some circumstances, such as deep burns, chronic wounds, and intensive skin loss. These chronic deep wounds may be subjected to repeat infections, which may not only delay but prevent the process of wound healing entirely. In severe cases of skin loss, it may result limb amputation or fatality. Conventional treatments include application of different types of dressing like gauze, films, and ointments, negative pressure wound therapy, autologous skin graft, and hyperbaric oxygen wound therapy. Conventional methods have been shown to be beneficial as wound therapy, although they possess some limitations, including the lack of healthy skin for autograft, donor site morbidity, and invasive surgical procedures. So alternative and complementary approaches are required to overcome conventional therapy limitations. To overcome the limitations of conventional approaches, application of specific stem cells have thought to be a promising approach to accelerate the process of wound healing. Generally, the treatment process involves seeding stem cells onto bioscaffolds to promote adhesion and proliferation to form a functional tissue that is then applied to the wound. However, stem cell therapy also have its disadvantages and limitations, such as limited self-renewal, increased risk of malignancy, complex and invasive harvesting procedures, costly, and are not adequate for wounds that are too large or deep. It may serve an alternative treatment in some scenarios, but it is not robust enough yet to replace conventional treatments. Fortunately, technological innovation gave rise to 3D bioprinting, providing a diversified range of therapy for skin injury. This technology was first introduced in 2008 from Lee's group. The top blue line represents the in vitro approach, and the bottom green line represents the in situ strategy. The evolution of bioprinted skin originated from the first simplified bilayer structures, containing only 2 cell types, to the most recent work and notable achievements, such as vascularization, infusion of different cell types, and the development of portable bioprinters. BioInk is a biological matrix used as a source of cell for the bioprinting process. It contains a mixture hydrogel and the desired cell population. The ideal BioInk possesses all characteristics indicative of biocompatibility, printability, and functionality to be considered suitable for use. In 2018, Kim's lab demonstrated a potential hybrid BioInk that displayed accelerated wound closure and neovascularization. In recent years, more advanced bioprinting methods have been established. Inkjet bioprinting is a non-contact printing technology that utilizes thermal or piezoelectric electric pulse to eject the bioink through a nozzle to form tiny ink droplets. It is good for DNA printing, but not optimal for cell-based printing, because the electric pulse affects cell viability. It also requires low cell density to avoid high shear stress and nozzle clogging. Pressure-assisted bioprinting. It is an extrusion-based bioprinting that relies on pneumatic force to eject the bioink from a nozzle onto a building platform. Less resolution compared to other bioprinting strategies, but can utilize a wide range of bioink with varying viscosities. The cons are that pressure may cause cellular damage and cell death. In the laser-assisted bioprinting, the laser irradiates a bioink-coated surface to create a bioink droplet. After that, the bioink droplet will be transmitted to the receiving surface. The many benefits of this approach includes the use of high-density bioinks, cell-level resolution, and the laser pulse does not harm living cells. The performance of artificial skins has improved considerably, powered in large part by new developments in 3D bioprinting technology. The only missing piece could be the multisensory function. As 3D bioprinting continues to develop as an innovative skin injury treatment, an alternative technology is also pioneered in parallel, giving rise to artificial skin. A multisensory artificial protective barrier that not only mimics skin functionality, but potentially augments and enhances its capabilities. An exciting new approach and breakthrough for skin injury treatments. Thank you.
Sunumu için Doktor Ellen Toyonaga'ya çok teşekkür ediyoruz.
Şadiyeciğim, bir iki cümle söylemek isterim. İzin verir misiniz sayın moderatörler bu üç sunucu hakkında?
Hocam
Tabii
buyurun
ki.
lütfen.
Bahar'cığım buyur.
These are amazing scientists and physicians, really. First of all, Ivana Kavikova, she's interested in neuroimmunotherapy, and she's pioneer in this therapies from the Yale University. Gabriela Turco, it is I would like to mention her surname, last name, Turco. She's married with a Romanian lawyer, actually, but her generation is coming from the ancient Turks. So she's amazing dermatologist, and she's especially pioneer of the melanoma tumors and 3D functions of the skin cells. And last presenters, Ellen Toyonaga, she's from Japan, and she's still working at the Yale University, and I love her presentation about bioprinting, right? It is amazing, the newest subject in this area. So congratulations, these three amazing scientists, physicians, and thank you for the joining attendance in our Congress today. I think so we will love to end of the session and these days, right? And also I would like to congratulate these amazing moderation, and your directorship. Thank you so much.
Biz teşekkür
Teşekkür
ederiz
ederiz.
Bahar'cığım. Bu kongrenin organizasyonu için, bu değerli katılımcılar için, emeklerin için, teknik ekibe çok teşekkür ediyoruz. Emeği geçen bütün arkadaşlarımıza çok güzel oldu. Birlikte olduk. Çok güzel bilgiler paylaştık. Adını duyduğumuz ama hiç görmediğimiz, uzaktan sevdiğimiz insanları, takdir ettiğimiz insanları görme fırsatı bulduk. Birlikte çalıştık, kaynaştık. Kongre bence amacına ulaşıyor. Umarım yarın akşam da aynı bugün yaşadığımız heyecanla, güzelliklerle kongremizi tamamlarız. Herkese çok teşekkür ediyorum ben katkılarından.
Yarın için bir müjde vereyim size. Yarın Amerika'da tıp öğrencileri ve yarışma birincileri de konuk olacaklar. Dünyada evet innovation'da özellikle tıp öğrencilerinin buluşlarını büyük bir heyecanla bekliyorlar sizlere sunmak için Quinnipiac Üniversitesi'nden. Innovation bölümünde sunacaklar. Görüşmek üzere. Çok mutlu oldum sizleri gördüğüm.
İyi akşamlar.
Teşekkür ederiz. İyi akşamlar.
İyi akşamlar.